This recording will go over potassium, which is the only electrolyte we're going to cover at this time. So the first thing you need to know is what is the normal serum value for potassium, and that is 3.5 to 5, and that is a value that you do have to memorize. So hypokalemia, or low potassium, would be a value of less than 3.5, and hyperkalemia, or high potassium, would be a value of more than 5. Early clinical manifestations of hypokalemia include fatigue, muscle weakness, anorexia, nausea, and vomiting. Muscle weakness does not usually occur until potassium levels fall below 2.5. Weakness usually begins in the lower extremities, progresses to the trunk, and may result in paralysis. Respiratory muscle involvement may result in respiratory arrest. Quadricep weakness may be one of the earliest signs of hypokalemia. Severe signs and symptoms include paresthesias, leg cramps, decreased bowel motility and paralytic ileus, confusion, rhabdomyolysis, and myoglobinuria, as well as dysrhythmias and cardiac arrest. You also need to know that changes or potassium levels that are not normal can result in dysrhythmias and ECG changes. And of course, at this point, I don't expect you to know the types of changes of the electrocardiogram or the ECG, but I do want you to know that if there's a problem with potassium, we want to be monitoring the ECG. Signs and symptoms of hyperkalemia, or high potassium, include cardiac dysrhythmias and changes in the ECG, early tachycardia followed by bradycardia, paresthesia of the face, tongue, hands, and feet, GI hyperactivity, including nausea, diarrhea, and abdominal cramping. Metabolic acidosis may also be present. So first we'll talk about treating a patient who has a potassium deficit, so low potassium hypokalemia. Treatment for hypokalemia due to excessive potassium loss depends on the severity of the deficit. Patients with low normal serum potassium levels may be advised to consume additional foods high in potassium. Foods rich in potassium include tuna and fruits and vegetables such as mangoes, oranges, avocados, tomatoes, cucumbers, spinach, strawberry, and bananas. Management goals for patients with hypokalemia include preventing and treating life-threatening complications, replacing potassium and returning levels to normal, and diagnosing and correcting the cause of the deficiency. Potassium replacements can be given orally or IV. Please review box 12.1 on page 164 for information about oral and IV potassium preparations. Potassium chloride is the most frequently used oral potassium preparation. It is used for treatment and to prevent potassium depletion. It is available as a liquid, powder, tablet, capsule, controlled release, capsule or tablet, enteric-coated tablet, and effervescent tablet, and for parenteral use. So just know there's many different forms that it can be administered orally, and you'll recognize obviously with potassium and the potassium of potassium chloride that it is a potassium supplement. In regards to nursing implications for oral preparations, tablets and capsules should be administered with or after meals, followed by a large glass of water while the patient is sitting up to decrease GI irritation. The patient should remain up for at least 30 minutes after the administration. Dissolve effervescent tablets in 3 to 8 ounces of cold water and ensure that the tablet is fully dissolved. Dilute liquid forms before administering via an enteral feeding tube. Powdered and liquid solutions can be diluted in 3 to 8 ounces of cold water or juice. Do not chew or crush enteric-coated or extended release tablets or capsules. Advise patients not to suck on tablets to avoid oral ulceration. Advise patients to avoid salt substitutes. So salt substitutes are high in potassium. And we don't want our patients taking a potassium supplement or preparation in addition to using salt substitutes and ending up having too much potassium. Now we're going to talk about nursing implications for IV potassium administration. IV therapy is indicated for patients who are unable to tolerate oral therapy, or in addition to oral therapy, for patients with severe hypokalemia. So with IV potassium, which is sometimes written as just the K there, with IV potassium, we never want to administer it by an IV bolus or push, right? So that's when I have a syringe of potassium and I put it up to the hub and I inject it into the patient. It's always going to be slowly administered, diluted, using an IV pump, right? So never administer undiluted, never by IV push or bolus. Infuse slowly, 10 milliequivalents per hour is the standard. Sometimes it can be infused at a higher rate if the patient's being monitored. For our purpose, we want to know the rate for potassium. The usual rate is 10 milliequivalents per hour. We need to use an infusion pump. We need to monitor the IV site and to make sure that we don't have any infiltration or extravasation, right? Too rapid of infusion may cause fatal hyperkalemia, okay? Signs and symptoms of toxicity include problems with the heart, irregular heart rate, beat, dysrhythmias, ECG changes, as well as fatigue, muscle weakness, paresthesias, confusion, and dyspnea. So for treatment of hyperkalemia or high potassium, if it's not too severe, potassium restriction by oral intake, so restricting the amount of dietary potassium the patient is ingesting may be used. Also, the following could be used together. So 10% calcium gluconate, and that's given, really doesn't do anything with the potassium itself, but it helps to protect the heart. Remember, those potassium abnormalities can have an effect on the heart. So the 10% calcium gluconate is administered to help to protect the heart. IV sodium bicarb, by elevating the pH level, which bicarb does, potassium moves back into the cells and thus lowers the serum level. And then insulin and glucose also helps to promote potassium to go back inside of the cells and get out of the bloodstream. So insulin and glucose, and it has nothing to do with being diabetic. So we're just strictly talking hyperkalemia. Your patient does not have diabetes. Insulin and glucose could be used to help move potassium back into the cells. And then also sodium polystyrene sulfonate, also brand name's K-Exalate for anyone who's used that. It helps to bind to potassium in the GI tract and to help eliminate potassium that way. And sodium polystyrene sulfonate can be administered orally or rectally. And different drugs can affect the potassium balance. And the two that I want you to be familiar with are diuretics and corticosteroids. So diuretics, sometimes the patient may call a water pill. So they're medications that increase urination. So diuretics can be classified as either potassium wasting, which can cause hypokalemia, or potassium sparing, which would make us concerned for hyperkalemia. So depending on the type of diuretic that the patient is taking, we need to be concerned with either potassium loss or potassium retention, hypokalemia or hyperkalemia. Corticosteroids are also common, and they can also cause hypokalemia. Now I want you to look at the nursing process box for potassium on page 166, and I want you to pause the video and I want you to pull out what you think is the important information that you need to be studying. Again, these nursing process boxes throughout the textbook contain great information that you need to be studying when preparing for a test. So don't ever just gloss over these nursing process boxes. Make sure you are focusing on them when studying for a test. So go ahead, pause the video, take your own notes, and then resume the video. So in terms of assessment, what do we need to know? We need to know the normal potassium levels, right? 3.5 to 5. We need to know signs and symptoms of hypo and hyperkalemia. We need to get a set of baseline vitals and ECG for the patient. In terms of planning, what do we want for this patient? We want their serum potassium level to be within normal range of 3.5 to 5. In regards to nursing interventions, we want to give oral potassium with sufficient amounts of water or juice, at least 8 ounces, and with meals. potassium can be extremely irritating to the gastric mucosa. Remember, potassium is IV. It's never IM, never IV push, never IV bolus. So it's given IV using an infusion pump, generally no faster than 10 milliequivalents per hour. We want to monitor urine output, and we want to monitor those kidney lab values, so the serum creatinine and BUN to monitor kidney function. We want to monitor for changes in the ECG. So those cardiac changes that can come around with abnormalities in potassium. We want to check the IV site because potassium, when it infiltrates, can cause extravasation and tissue necrosis. And if we do notice that it's infiltrated, we want to discontinue the IV fluids immediately. In regards to patient teaching, we want to make sure the patients are having labs drawn as needed to monitor potassium levels and any other labs that the physician is going to be monitoring. We want to make sure they're drinking the full glass of water when taking oral supplements and taking the supplements with meal. And we want to teach them it's because it's going to upset your stomach and irritate the stomach if you don't do that. We want to encourage them to comply with the prescribed potassium dose, any labs, and to attend any follow-up appointments as needed. We want to make sure they know the signs and symptoms of hypo and hyperkalemia, right? So they can recognize if maybe something's going on that's due to a potassium imbalance. We want to make sure they can recognize foods that are high in potassium. In terms of evaluation, we want to evaluate the patient's serum potassium level. We want to see that it's between that 3.5 to 5, the normal range. And we also want to monitor ECG readings to ensure the patient has their normal baseline rhythm without any dysrhythmias. All right, we're going to go over a couple practice questions. Go ahead and pause the video, read the questions, and pick out your answer, and then resume the video to see if you're correct. For practice question 3, the correct answer is C. For significant blood loss, blood products are needed because they're the only fluid replacement solutions that have products that can carry oxygen. For question number 4, the correct answer is C. For mild hyperkalemia, which would be 5.4 to 5.6, potassium restriction is normally effective. And this last one I should have taken out, but if you want to do it for fun, if you've looked into calcium hypercalcemia, go ahead and pick out your correct answer. For question number 5, the correct answer is B as in boy.